Dr. Zeev Neuwirth is a healthcare executive with over 15 years of clinical practice and another 15 years of experience in leading enterprise-wide programs and developing innovative strategies. He is the author of two books, Reframing Healthcare, a roadmap for creative disruptive change, and Beyond the Wall, and he is the host of the podcast, Creating a New Healthcare. Dr. Neuwirth is a physician leader who uses his books, podcasts, speaking engagement, and leadership to transform how individuals and organizations approach healthcare. He received his MD from University of Pennsylvania School of Medicine and completed an internship and residency in internal medicine at the Mount Sinai Medical Center in New York City. He also obtained a degree in healthcare management from Harvard Chan School of Public Health. Without further ado, let's jump in. Making a difference in healthcare requires collaboration between researchers, startup founders, and policymakers. This is what Delta is about, hosting conversations with leaders on the path to serious innovation. Hello everyone, my name is Rupen, and I'm a physician on a journey to meet people who are making a delta in healthcare. All right, thank you so much, Zeev, for being here today.
Pleasure.
Thank you so much. And for all our listeners, especially physicians, I recently read Dr. Neuwirth's book, and it's amazing. So today we're going to talk about his book and his accomplishment and the changes that are going on right now in healthcare. They are very exciting. And again, thank you so much for being here today.
Oh, it's so much fun to talk with you. Thank you for inviting me.
All righty. So I want to go to your book. And I think all of us as physicians or healthcare workers had that moment where we hit the wall. And at the beginning in your book, you talk about the moments that made you hit the wall and made you realize how healthcare delivery is suboptimal. Can you talk to me through those experiences and what really made you change your career direction from practicing medicine to wanting to make a change in healthcare?
Mm-hmm. Yeah, so Rupen, like you, I, practiced for a number of years, and I think very much like you, I think we've shared this in common. There were so many things we saw that were so frustrating to us, right? In terms of trying to get the work done and trying to take care of patients and trying to deliver outcomes, right? Really, the outcomes we know we could be delivering. And, I'd gone through probably over 2 decades of a career practicing and then also part-time managing other physicians in large organizations, and then shifting to being an executive. And, I carried that frustration with me pretty much every single day I went to work, knowing that we could be doing so much better. And again, I mean, I'm talking about for patients and their families, but I'm also talking about for physicians. I had studied burnout back in the 1990s, and it was so bad even then. It was just terrible.
Really?
So oh my God, it was terrible. I did a study when I was a young attending. I
Mm-hmm.
used the Maslach Burnout Inventory, the MBI, which is the standard industry tool for measuring burnout on 3 different domains. I used it before anyone really knew what it was, and I did it in New York City. The MBI, the people who actually processed the results, actually called me up and they said, "Are you sure you did it right?" And I said, "Why do you
Oh
ask
my
that?"
God.
Yeah, and they said, "Because the burnout is just, we've never seen anything like this before in other industries." And I think at that point, I'm not sure they'd actually. I think it was still relatively new in healthcare, and they didn't have a lot of experience with it. So yeah, it was really, I mean, we scored in healthcare lower than any other industry by far in terms of, the MBI. And so, yeah, no, I knew about this, decades ago. And so I carried this with me. Literally every day I was practicing, and then I was an executive and responsible for really supporting so many doctors and nurses and techs, and then really, even more importantly than that, I was really accountable for the quality and safety of care for tens of thousands, actually at one point hundreds of thousands of patients that we were providing care for. And but what really, like to your point, when I hit the wall, there were three things that happened. And this was about 2014. Um, the first was that my mother went in for an elective hip replacement into an amazing hospital, amazing surgeons, amazing nurses and staff. And she didn't come out of the hospital alive, and she perished from a series of medical errors and mistakes. She perished from a hospital-acquired condition, and totally preventable, totally avoidable, tragic, so upsetting to me and my siblings and my father to lose my mother. She was 71 or 72. She was young and healthful and vibrant and smart and fun and so loving and caring. It hurt so much, but what hurt also was I knew the statistics. And I knew that that day that my mother died from an avoidable, completely preventable set of medical errors and mistakes in that hospital, I knew there were probably 1 to 2,000 other families that very day who had a similar loss due to preventable or avoidable complications in the hospital. 1 to 2,000, and that is every single day. And those are conservative numbers. We know that hundreds of thousands of people die and are maimed each year by medical errors and misdiagnosis in our healthcare system. That was the first straw. The second straw came within a year of that. I was sitting in my office, actually in this office, at this chair, at this desk on a Saturday morning in my home, and I got a text. And the text said, "Did you hear about Dr. So-and-so?" Dr. So-and-so was one of my best friends, was an amazing primary care physician, one of the best I've ever met. He was actually my primary care physician, although he reported to me at the time as one of our highly innovative doctors. And the text told me that after a week of seeing patients, the night before, Friday evening, after he saw his last patient, he got into his car, he drove to a nearby park, pulled a gun out of his car, and shot himself in the head. And I sat there when I got that news, completely stunned, completely stunned. The thoughts that go through your head when a close colleague and friend commits suicide, I would never have anticipated. The emotion and the thoughts that I experienced that morning. A few hours later, I'm still sitting here at this desk, at this chair. My head is looking down at the carpet below me, and I just said no. I said, that's it. I knew, again, the stats. I knew that every single day, 1 or 2 doctors take their lives. I knew that burnout at that point was 50% of all medical providers have burnout. And I just started shaking my head. I said, no, I'm not going to, on my watch, this is not going to happen. I am not going to just go through my career, do the usual things, practice medicine, be a manager, be an executive. It's just not going to happen that way. I'm going to do something to stop this madness and to stop this inhumanity. And that's when I decided I said, well, where do I go to find people who are thinking differently, who are doing differently? And I don't mean process improvement. I was a process improvement expert for years. I did lean Toyota production system, large scale for years, Six Sigma, quality and safety, population health. I'm not talking about that. Those are all important. Those are all good. But I'm talking about really transforming the system, really redefining what it means to be effective, really making a difference. And you know as well as I do, Rupin, that all the data shows us that we've been heading in the wrong direction. That was 2014 through 2016. Now in 2024, longevity is going down in this country. Quality is getting worse. Safety is getting worse. Complexity is getting worse. Cost is getting worse. And inequities of care is getting worse. We are heading in the wrong direction. And so I was scratching my head and I decided, let me just call up people. So I literally picked up this device, my iPhone, and I started to call people around the world, people around the country who I'd read about who were really thinking differently. They were divergents. They were positive deviants. They were rebels. Humanistic rebels is what I call them now. And I literally sat on the phone for an hour, 2 hours, and I would interview them. And I would record those interviews. And then I would transcribe those interviews, hundreds and hundreds of these in-depth interviews, to try to decipher the pattern. What is it that you're doing that's different, that's getting these different results? How are you thinking? And out of those interviews, and mostly out of the studying of those transcripts and other studies and other research. And by the way, I was doing this at night and on weekends. I had a full-time day job all this time, but I started to really see a pattern. And so I wrote it down, and it became my first book. It was called Reframing Healthcare. And it was essentially their playbook. It was the playbook of these humanistic rebel leaders, these transformationalists. And so I shared that with the world in Reframing Healthcare, which was published in 2019. I started a podcast, which really was nothing more than me taking some of these interviews and sharing them. Not all of them, but some of them, and sharing these very, very enlightening and encouraging and hopeful, inspiring interviews with people. And to me, they are just, it's almost like watching a movie. It's that kind of elation, and like a heroic movie. And then I published a second book just most recently in September of 2023, a few months ago. And that came out after about 7 years or so of these in-depth interviews, 7, 8 years of this. And that book was really a distillation, the one you were referring to, Beyond the Walls. That was really a distillation of not how they were doing it, but exactly what they were doing. It's a three-part strategy. It's the only strategy that's going to humanize and transform healthcare in America. And I wrote it down, and I shared it with lots of stories and examples, and of course, lots of data to support it.
Thank you so much for sharing this. It is very hard to talk about these memories, and I hear you. I've been through that experience, the shock. You don't believe it. You have that strange feeling in your stomach, and then like some people just say it is what it is, and they go to sleep, and then they wake up the next day and continue. And some people like me and you say no, like we should make a difference, like we should change things,
Mhm,
right?
mhm,
Um,
mhm,
Thank you for bringing
mhm,
up also your first book, Reframing Healthcare. Uh, what are, I just want to like also for our listeners, if you're going to leave like
mhm.
quick message or a quick like summary of the book, what are the main messages from that book?
Yeah, I mean, the main message is that the people who are really changing healthcare, who are, what I would say, transforming healthcare, humanizing healthcare, they're doing it in a different way. So, and it's not incremental. It's transformative. They're doing something called reframing, and I had never studied this before, never heard about it before, really. I used the term, but I used it very specifically. And essentially it comes down to 3 or 4 major steps. The first step is they have a different orientation. So they just something clicks and they see the world differently. So there was a different orientation. And then in that orientation, they redefine the problem differently. And then they redesign the solution based on that redefinition. And most importantly, they actually put their money where their mouth is. So they don't do pilots. They actually put their resources into this newly designed approach. And so that process of reframing is essentially what I shared and I go into in depth with. And so let me just give you like a brief example. So it actually, you could tell us, there's so many stories I could tell, but one of which is Omada. So Omada is one of the first most successful digital health companies in the country. And Sean Duffy, who's the founder, was actually in medical school and business school at Harvard. And he's there on Longwood Avenue in Boston, where all the medical centers are. And he's seeing all the patients who come in every day to see the doctors. And he was sort of scratching his head and he was asking himself, we have the technology. Why wouldn't we actually deliver some care to people at home as opposed to them going, coming in? Now, he had that thought in 2008 and 2009. Okay. It's now 2024. I mean, he was way, way, way ahead of his time in that thinking. Step one, the reorientation. Why couldn't care be delivered at home, where the point of care is actually the point of need? That that thought was literally years ahead of where anyone else was at that point in time. So he actually then, with that, started to redefine the problem, and he said, well, how would you deliver care at home? How would you take sort of a bona fide evidence-based medicine care and deliver it at home? So he took the example of prediabetes and the National Diabetes Prevention Program, which had been researched at that point in time. It was a 16-week program to help prevent diabetes for those who had prediabetes, and it was delivered in a classroom through 16 sessions. And he said to himself, I wonder if we could actually deliver that virtually so people could do it anywhere they want. And so, and part of that program is getting blood pressure readings, getting weight readings, conversations, things like that. So he started to redesign care. He left medical school, he left business school, and he went to work at a tech company, and then he worked at IDEO, a design company, and he trained himself and he built the company. He built the process. He redesigned care, literally, and then he devoted his entire, not just a few bucks, he devoted his entire career to actually, and all his resources, and raised capital, and essentially created a completely differently organized care. So there's an example: reorient, redefine the problem, redesign care, and reorganize it through those resources. That's reframing healthcare. And I have hundreds and hundreds and hundreds of examples of that, literally examples that I've learned up till like this week or last week. And it's happening all the time. The challenge is, one of the challenges is we really need the leadership to start to actually incorporate that at scale, and in the care system itself, which includes payment. I'll stop there, but what I discovered, and the reason I wrote the second book, was that wasn't enough. We needed something else, and that's what I share in the second book. Leave you guys hanging.
Yeah, thank you so much for and I read Umada's story and your interview as well. It is very inspiring, like it's a very gutsy move. It's not easy, like leaving Harvard Medical School and business school and throwing away all that income that comes with the work as a physician and saying, hey, I'm going to go work in a tech company which pays like fraction of your salary as a physician, and taking it is a scary, but like kudos to him for sure. It's like
Mhm.
it takes lots of power and energy.
Well, that's and
Yeah.
that's why. Well, thank you for saying that, Rupen, and you're exactly spot on. And that's why I call these folks humanistic rebel leaders. It really, he was all about humanizing healthcare, and it took sort of a rebel leader mindset to do that. And but he reframed, as many others have. And again, I don't think all of us need necessarily to be like that. But we need to do what I describe in the second book, Beyond the Walls. We need to be part of a larger strategy and lead to a larger strategy that can accept the work that these humanistic rebel leaders are doing.
Since we're talking about digital health, maybe we can also like go deeper in that. So I think you talked about it, that at one point creating digital health was not enough, but the adoption from the leadership wasn't there, or maybe it's not there yet. So I want to ask you a question. It's like two folds. First, like,
Mhm.
do you think that right now the current leadership in different hospitals are taking enough steps to implement digital health, or no? And what are like the challenges?
Um, well, the challenges are many. you know, I hate to say this, but I do think that, well, maybe let me summarize Beyond the Walls quickly, because I think it in part answers your question. The strategy that I think is really necessary for leaders to adopt now to humanize healthcare and do it in a timely way, because I think everyone, I would say the vast majority of leaders, I'm in awe of leadership. I mean, you talk to or listen to or read or meet these folks who are leading these healthcare systems. They're smart, they're dedicated, they're hardworking, they're good people, they're brilliant, they're amazing. I mean, it's just I am in awe of the people in healthcare. It's just I mean, I don't know other professions as well or other industries as well as healthcare, but I can't imagine that there is an industry that has people that are as just good and decent and smart and hardworking as healthcare. So I think the people are well-intentioned, well-meaning. I think they're driven and purposeful and have great values. Having said that, our strategy is all wrong. The strategy that I've seen these humanistic leaders adopt is this. You have to lead primarily with humanism, okay? That has to be your guiding light, not like a vision statement or not a mission statement. That really has to be what you do every single day. You measure yourself. Are we humanizing healthcare? And by the way, when I say humanizing, this is what I mean. Right now, healthcare is full of racism and sexism and ageism and ableism and classism and industrialism. We all feel like cogs in the wheel of this industry. And humanism is getting rid of all that. It's taking all that down. That's what humanism is, and you can measure that and you can work to that. And so I really think that that's got to be the fundamental principle. That's got to be your strategy, humanizing healthcare. The two enabling strategies, and this is really important. Number one is what we just talked about and what you want to dive into further, which is the digital and technology infrastructure. We have to move much faster in that, and I'll say something about that in a moment. And the other is the business model transformation. Technology by itself will not work unless we change the business of medicine, unless we start to really look at how we are paying, physicians. The fee-for-service model. Do you know that we realize in this country that the fee-for-service payment model was absolutely wrong and inadequate and completely misaligned with the care, what we want out of care delivery? We realized that in the 1930s. There was a report sent to the President of the United States that said we need to get rid of fee-for-service in the 1930s, and we need to move to a model that is capitated, that will
Really?
allow, yes, really. And by the way, it was in the 30s. We talked about it again in the 50s and the 60s and the 80s. I mean, this is a conversation we've been having for literally almost 100 years. So we've known that the business model has to change, okay? And yet we've not changed it, right? And today, I mean, I call the book Beyond the Walls because we're still like, we act like medieval castles with walls around them and moats around those walls. I mean, let me say nothing more than electronic medical records. I mean, if they're not castles with moats, then what is? I mean, we've known about interoperability from the beginning, and we're not doing it. Not because we can't, but because we won't. Not because it's not the right thing to do for patients, because we know it's absolutely the right thing to do to transform healthcare delivery, to make it safer and higher quality. But we're not doing it because of profits, and profits, I don't mean profits as in PROPHETS. I mean profits as in PROFITS. It's profits over people. It's profits over care. And so we build these moats. So we have to, and that's a business model transformation. That's not a technology transformation. It actually is both, to be honest with you. And so, but we need to transform the business and we need to transform technology. I was just talking to someone, an expert in AI. So artificial intelligence is getting more powerful. It's doubling its capabilities every single year. In 5 years, it's going to be 30 times more powerful. In 10 years, it could be potentially 1,000 times more powerful. How fast are we moving to adopt that? how fast are we moving to understand that? How fast are we moving to learn it? It's not, I mean, I think our conceptual frame of technology, we still think of it more as like construction, as physical construction, as laying a brick on top of another brick, very, very linear, slow process. AI doesn't work that way. Digital technology doesn't work that way. I mean, Moore's law has been around for a while. You know, yes, some of it you do need physical infrastructure to change, but now with digital technology, you don't need to physically change anything. I mean, it's literally prompts and electrons moving. And, you know, so I think to your question, I do think that no, I think we need to move much faster on digital technology. We need to really dive into it more. I mean, if for no other reason right now, you look at all the cybersecurity issues that are going now. I mean, it's not a question of whether you're going to be attacked. Or if you're going to be attacked. You're going to be attacked. You have to be ready for it. We have to have a completely different mindset about digital and technology. And you know, I'll be honest with you, I'm as guilty as anyone else. I should be spending much more time becoming much more proficient at this. We should be investing much more in it. Um, I think that, and others have written about this, which is why I think it. Experts have really written about this. I mean, I think finally we have the tools to really catalyze and enable a humanistic transformation of healthcare, and it is through digital, coupled with changing the way we do the business, to be humanistic. But that humanism is the top one with digital and with business model transformation.
Thank you so much. That was very uh, detailed answer, and I really like how you focused into, like, especially on the business model. You know, like our notes became like the EMR became our jail, and I think going back to your book, that's where the beyond the
Yeah.
wall came from, right? Like
Yes. Yeah.
it's you have to put a physical exam paragraph in the note because insurance won't pay unless you have that. Although, like, sometimes many physicians won't even touch the patient or do physical exam, it's just copy paste a normal physical exam. There is that too, like I've seen it a lot, or review of system or things like copy paste just to fulfill the criteria, or sometimes like the patient's ID in the beginning, which like doesn't make sense. Like it's I completely hear your frustration, but I never thought
Right.
about it in
Yeah.
terms of business model. I always thought about it that healthcare does not adopt technology fast, but now after you talking about the business model, there is that part too.
Well, and let me, let me be even more concrete. So there's, in Beyond the Walls, the book, in the last third, I talk about a couple of business model transformations. Payment is one of them.
Mm-hmm.
I think another one is partnerships. We need to start to partner radically different. The idea that if it's not built here, it's not going to happen, which, most healthcare systems, that's the way we grew up. That's the way we think. It's that build or buy decision. It's just, no, we don't have the time to do that anymore. Who has except with rare exception, who has the resources to build everything by yourself? It just makes no sense. Which we have to radical, just like digital is a radical transformation, business partnerships are a radical transformation. We need to radically partner in ways that we can't even imagine yet. And there are examples of it, which I give in the book, lots and lots of examples. So I'm not saying this is a hypothetical or we have to figure out how to do this. It's being done. We just need to actually do it faster and better and bigger. The other business model transformation is called platforms. And again, I'm not making this up. There's one called Amazon. You may be familiar with it. And so that was a joke. And so, Amazon yes, there's a technology to it, but Amazon fundamentally is a different business model. So most business models, you take raw resources, you do something to them, then you sell them. Okay. It's very, very linear. A platform doesn't do that. A platform creates, it's like an old marketplace, right? Essentially, it's a marketplace. It says it brings customers and it brings vendors together. And the technology, of course, makes it much more easy. It collapses it. So it's much more cost effective. It's much more convenient. It's better customer service, better experience, better choice. That's what a platform does. I think we need to bring that business model transformation into healthcare. Now, I say I think, I don't have to think because it's happening, right? So Amazon, the greatest platform, in the world, business platform in the world, is now in healthcare, and they're now taking that and creating a platform. But I think hospitals, which used to be the platform business model, and have moved away from it. I think hospital systems, healthcare systems can also become platforms. I think that I actually do think that the platform revolution is going to transform healthcare, and it is not just a digital transformation, it is a business model transformation.
I'm curious to hear your thought. How do you think a hospital can become a platform? I'm happy to hear your vision.
Well, um, you know, one is, and they are trying this, but one is can one of the concerns people have is that healthcare is so fragmented, right? And so you have all these point solutions that are, where, I'll have a diabetes app, and then I'll have a COPD app, and then I'll have,
Correct.
this app and that app, and I go to this place and that place. I think hospital systems are, first of all, they're in the community. They have the trust. They have the resources. What if they actually became the connector, the convener, the agora where you thought you would go to the hospital? What if they pulled all these, instead of having to build every single thing? What if they said, no, you know what? We're taking care of 1 million patients, or 500,000 patients, or 2 million patients, and we're going to create an ecosystem of care, where literally seamlessly, effortlessly, they're going to, be able to get the care, and that'll include virtual care and asynchronous care. And again, not with the plotting, and plotting as in like antiquated technology that we've used in the past, but with state-of-the-art technology. I I really think there's an opportunity. I think Mayo Clinic, their CEO, and they have, I'm blanking on his name. They have a physician who came from BI, a chief information officer, who is, really, I think they have that vision of really creating that. I think Providence Health, in Washington, has that vision as well. So I think there are places that are beginning to say, we could be that platform if we really kind of, made that leap, if you will.
Gotcha. And since we talked about the platform and you touched on the um, big ones, the titans, we talked about Amazon. I'm also curious to hear your thoughts about Walmart leaving healthcare. Um, does that reflect it's not enough profit for Walmart? It's not the dream business for them? Or is it like healthcare is so hard, they said like, I'm washing my hands, I'm out of this game?
Yeah. So, Walmart is the largest company, in the country, maybe I think in the world. It's number one, right, on the Fortune list. So, I would find it hard to believe that anything is too hard for them. I don't think hard is the problem. They've been a visionary leading company, in terms of supply chain management. I mean, they're just, I mean, they were way ahead of their time, and they're brilliant and, exceptional in so many ways. So I don't think it's hard. I think clearly they made a business decision, a strategic decision, about where they want to place their capital and their investments. And so they're going to do what's right for them, and the viability of their organization and the future, and what they believe would best serve their customers. I think that the Walmart decision, and again, you could bring others into it as well. Walgreens is shuttering, most of their primary care clinics. CVS is not moving into primary care in the way it said it would. So we're seeing this. Even Amazon has had a lot of stuttering in primary care. And so, I think it's less a reflection on, has anything to do with the retailers. I think it's really, the real story is about primary care. I think that it's not that primary care is hard, it's that it's just not a viable business model. I mean, if I mean, primary care in this country is really a feeder for specialists and surgeons and hospital systems. I mean, I don't think I'm saying anything that anyone doesn't already know. It in and of itself, primary care is not a viable business model. It's not. It's completely under resourced. I mean, and I say this in part because you look at other developed nations, they're spending 10, 12 or more percent of all their healthcare dollars on primary care. Do you know what percentage we spend in this country? It's 5%. We spend
Really?
half
Wow.
half of what the other countries spend. And our results, why is it that, if you look at that graph, classic graph now, which is getting worse and worse, you see the rest of the countries and they're all kind of clustered in terms of cost. And then you see the US way, way more costly and getting more costly. And then you look at longevity, lifespan, and you see the other
Yeah, we're
countries getting
dropping.
higher and higher, and we're dropping. So we're way costlier and people are dying at a younger age. Why is that? One answer, because we're not investing in primary care. And it's you look at the salaries. I mean, why is it? I mean, you're in healthcare, this. You have friends and colleagues. You made a decision about your career. I mean, why is it that so few medical students and residents are going into primary care? Why are they going into specialties? Is it
It's a
is it
salary.
inherently primary? It's a salary.
It's
I
a
mean,
salary,
when
let's
you
be
go through,
honest.
right? It's the salary. Okay, it's definitely the salary is a big part of it. No question about it. When you go through medical school and you come out and you're in hundreds of thousands of dollars of debt, and you have a choice between primary care and making 150 to $200,000 a year, or you can become an orthopedic surgeon or someone else make $1 million a year. What are you going to do? I mean, it's necessity. I mean, it's just that's number one. But it's more than the salary. I actually think it's the bigger issue. Not that that's not a big issue. An issue that is also big is that you know they say that I apologize, but they say that shit rolls downhill. So everything goes to primary care. You're a surgeon.
Correct.
You walk into the OR. Okay, you're a surgeon. You walk into the OR. Do you walk in alone? Of course not. You've got a team of people around you. You've got the best technology money can buy around you, as it should be. You're a primary care doctor. You walk
You have
into
not
the room
one.
alone. You have no one. You do
Correct.
everything yourself, right? You spend hours every day writing notes, looking things up, right? And on top of it, what's your technology? You've got a fax machine in the back room. That's your state of the art technology. Okay.
Yes.
So how absolutely who and all the psychosocial issues and the social determinants of health and all the logistics and all the denials of care and all the insurance companies, all those hassles roll down to primary care. I'm not saying these specialists and surgeons don't deal with it, but disproportionately, it's in primary care. Why would anyone want to take a career where that's going to be your life day in and day out? You're not going to make a fraction of the salary, and the work is so frustrating, and you're so unsupported. And so, for me, that's when you ask about Walmart, I know this is, it seems like I took us to a completely different place, but I did because the story, I think the point is we missed the joke. Everyone's talking about Walmart, 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 Walgreens, et cetera, et cetera. Let's talk about primary care because that is fundamentally the problem. The problem isn't Walmart can't do primary care. The problem is primary care is not doable in this country. And it's not, you look at the results, you look at the outcomes. Why is it that 60 to 70% of primary care providers are burnt out? Is it because they're weaklings, that they're not resilient? Of course not. They're amazingly resilient. I mean, you go through medical school and residency, you're resilient. Okay, you're resilient.
Exactly.
And
You're
you
doing
have
26-hour call shifts. Like you are resilient.
you're resilient. It's not the work. And it's not what it is you're burnt out, you're demoralized from all it's death by 1,000 cuts. When you take someone who's that bright and that dedicated and that's just so passionate about taking care of patients, and you say to them, actually, half your time is going to be doing data entry and data retrieval. That's what we're going to do, doctor. That's what your job's going to be. How many days or weeks or months or years can you do that before you just get burnt out and demoralized, you know? And so I say that only to point out what is obvious to me, that we need to radically reform, and like now, not 10 years from now, we need to radically reform primary care. And again, it's no different than what I was saying before. It's a humanistic mission strategy, but you need digital transformation and business model transformation. And in this case, the business model transformation is number one, stop paying fee for service, start paying a capitated, probably need to double the payment into primary care to keep it, make it aligned with other developed nations. And then we need to really resource it with the technology and the infrastructure and the teams that other aspects of healthcare have, and rightly so. So I think in some ways, we talk about disparities and inequities. I think that there's a major inequity in healthcare, and it's a bias against primary care. And for me, it is one of the top issues that we won't transform anything unless we transform primary care.
I love it. I can't agree more. Actually, I want to like support that. One of the reasons I didn't do internal medicine, I had to face this choice between going to specialty and internal medicine, is because I did not want to deal with social issues. That was like the main reason. I don't want to go to attend social meetings every day at 12 o'clock and figure out who's going to be discharged and who's not going to be discharged, and figure out the social issues for all my patients. And kudos to all the internal medicine docs who are out there and dealing with this. But that was one of the main reasons. The pay was like okay, although like if you go to specialty you get paid more. Lifestyle was okay with but the main point was like I can't do social issues for a long run, and I knew that's going to burn me out. And like I can't agree more.
Right. And again, I think um, a radically improved primary care system, the MD, the doctor should not be doing that. You should have a team of people, you should have the technology, and it all exists. I mean, you look at organizations like we talk about, go back to reframing. You look at Rishika Fernandapule. Years ago, he reframed primary care by creating Iora Health. He's got a team of people. The doctor is not the one that does that work. They've got a navigator, a counselor, a social worker. They have nurses. They have people who literally will do all of that psychosocial work, and they do it, quite honestly, probably better than the doctor, at a fraction of the cost. And you let the doctor do doctoring, right? And they become, and that's what I'm talking about, that team, that infrastructure, that technology, all that enablement. So it's not just this, to your point, it's not just the money and it's not just the salary, it's what we do with it to really transform healthcare.
I agree. For the sake of time, I just want to go back to your point, because to your book, there are some couple of things I want to talk about it before we end the episode. And you talk about home and sorry, care at home in your book, and it's a chapter that resonated with me, and I think that's the future of care. You discuss that the hospital at home has four pillars. For the entrepreneurs who are listening, can you explain what are the important pillars they should include in any innovative solution to make it easier to bring the care from hospital to home?
Yeah. So the most obvious part is probably the easiest, and that's the actual clinical care. So actually doing clinical care in the home is not that hard. It's like, again, we have the virtual technology, putting the protocols together. We know the medicine, we know the protocols, we know the pathways that can be developed. Important to do that, but that pillar is pretty straightforward, pretty obvious. The pillars that get you, the ones that are really challenging, of course, are number one, the technology itself, right? And so getting the technology, or maintaining the technology, and choosing the technology, and all that sort of stuff. That is one of the, and making it easy for people to use, right? So it's got to be human-centered technology. It can't be cumbersome. It has to be able to, patients and their family members have to be able to use it. nurses and providers and doctors have to be able to use it. So that would be, I think for technologists, it's really, really important that the technology has to be as intuitive as possible, as easy to use, as safe as possible. So that's one pillar. The one that's probably the most interesting and the most challenging is something that most of us don't think about. And I learned this through interviews with, the world's experts in this domain, and also through doing it myself. The one that gets you is logistics. So the logistics are really, really hard. Like, how do you get the equipment into the home in a timely manner? How do you modulate the equipment? Because you can't, you don't want a whole hospital room in the home if you all you need is a blood pressure monitor. So you have to modulate, what does the patient actually need? And then if they don't need a bed anymore, we got to get the bed out. If they don't need, a specific monitor, we got to get it out. So it's actually delivering the supply chain, the logistics. It's almost like a combination of like the logistics that a FedEx would use, or um, like a Geek Squad. And so it's that sort of like, how do I get the equipment and the people, right? It's the people too, because sometimes you do need people in the home. When you need them quickly. And so like for example, in a city, it might be very, very easy, quick to get like an ambulance to an apartment. Whereas, out in a rural area, it's a whole different logistic, nightmare, if you will. It's a whole different set of challenges. In a city, maybe, and this has been done, actually, I think it was done in Israel, you may not want a huge vehicle. You may want like a motorbike that can actually move in and out of traffic to get like a paramedic into the home quickly. So I think what most of us don't think about as much is that pillar, if you will. That's the one where I do think technology can actually, the most advanced technology can actually really help us the most. So um, it's and then I think the other pillar, of course, is the payment issue, right? So, and that's the one that's, again, going back to what we talked about, it's not just the technology, it's not just the logistics. I do think we have the technology and the capability to develop it. And by the way, we know even from the current state that it's much safer and much and very cost effective to have people get care in the home. We know that falls and delirium and length of stay and readmission rates and infections and nutrition, all those things are much, much safer and higher quality, better outcomes in the home versus in a hospital. For, I would say at this point, a significant percentage of people who are hospitalized, and we actually know that the death rate is lower in the home than and which is probably the most important thing, that mortality is actually lower in the home. It's safer to be in your home than in a hospital. And we know the cost is far, far less in the home than in the hospital, because you don't have all the brick and mortar infrastructure. So we know it works. The biggest problem is the payment reform. And we need to start to really shift that payment into the home. Now, I will say something, which is, I hope I'm not coming across as pessimistic, because actually I'm not. I'm incredibly radically optimistic. I am, and I choose to be that way. That's not my nature, but I actually choose to be optimistic. I will tell you, CMS is putting out codes at the home. I don't know that most of people who are listening are aware of what's happening, how payment is actually shifting increasingly into the home. There are so many codes now for so many aspects of care, not just hospital in the home. I'm talking about chronic disease management. I'm talking about navigation. I'm talking about social determinants of health. You can do good and do well by delivering care in the home, and it's getting better and better literally every few months. So I am, but that's a part of it that's really important too. So again, it's not just the digital and technology part. It's clearly not just the medical part. It's actually the payment part, which is getting better and critically important. And I do think we're at a tipping point. I think that people are going to start to realize, oh my God, I can actually make a living by delivering care in the home, and it's better care. And I think I predict we're gonna see a tipping point. Probably not. I don't usually like to make predictions, but my gut tells me that that's what we're gonna see.
Yeah, I completely agree with you. Like I have tons of patients who I keep in the hospital for 5 days just because like they want to have an MRI or they have to get a brain
Oh
MRI or
god.
something. Let's say not brain MRI, let's say like abdominal MRI or so. So the indication of monitoring is not there. The indication of testing is there. So I can discharge this patient home and I can bring them back when I have a spot in the MRI machine and get it done. But like no, because like if they got discharged, their MRI is going to take 3 months to
There you
happen,
go.
which
Right.
is mind blowing.
It's mind blowing. It's yeah. I mean, you and I and others we could probably sit here and say
Oh,
this
non-stop.
makes no it makes no sense.
I
Right.
completely agree. In respect of your time, I think we're over our time. Just like the last messages from your book, Beyond the Walls, for healthcare executives, what are the messages they should read, or what the message you are trying to send from your books to healthcare executives?
Well, I think, obviously, read the book, share the book. Um, it really outlines the strategy, the approach. It shows the examples. It shows what we could do. I'll tell you where I'm going now. So maybe I'll answer it by telling you what comes beyond the walls. I do think fundamentally the issue is one of leadership. I think that we must, and I believe we will, adopt a new leadership mindset. And again, this is not about leaders, this is about leadership. I believe that the era we've been in has been a era of status quo leadership, um, incremental leadership, leadership of gain, personal gain and organizational gain and profit over improving the human condition, a mindset where we don't challenge the predominant narratives again, and at least not with the urgency that we need, and using antiquated tools and antiquated approaches, improving things where we should really be radically transforming them. We of course we need to make things more efficient and more effective, but what the time calls for now is to redefine what it means to be effective. That's really what transformation is. And that's what we need to do. And so I believe that we need to move from that era of status quo leadership to an era where we have humanistic rebel leaders, where they really, people talk about having fire in the belly. The fire in the belly we need is to radically humanize healthcare. And I've actually begun to distill and outline these actions and these mindsets, from beyond the walls. It's a beyond the walls mindset. And if you read the book, you can see it throughout the book, but I've begun to make it much, much more explicit. And so I think fundamentally we need this beyond the wall strategy, this humanistic strategy coupled with digital and with business model transformation. But underneath that all, we need a mindset that I quite honestly do not see in healthcare today. And that is that humanistic rebel mindset. So stay tuned. That's coming soon.
Thank you so much. I really appreciate that. And for all those who are listening right now, like it's a great book. I read it. I think we have tons of problems in healthcare, and Beyond the Walls, it's a book that is full of solutions. So highly recommend it. I really enjoyed reading it, and it gives you ideas about the solutions out there. So if you have a practice, if you have a hospital, if you have a clinic, I'm sure there is a solution for your problem in the book. And again, Dr. Neuwirth, thank you so much for being here today.
Rupin, my pleasure. Really enjoyed meeting you. Take care.
Thank you so much.